Welcome back, everyone. The Coordinating Minister of Health and Social Welfare, Professor Muhammad Ali Pate, says the Bola Tinubu administration continues to demonstrate commitment to improving healthcare access for vulnerable Nigerians through its support for the National Health Insurance Authority's fistula-free program. At a press conference, the minister praised the progress made in providing free and effective treatment to women suffering from obstetric fistula and commended the leadership of NHIA under Dr. Kelechi Ohiri. Let's hear from the Minister and Dr. Kelechi Ohiri.
I think since the launch of this, we've seen significant change in terms of the care, the remediation that women who have obstetric fistula have received. I will hear more from the DG. I visited one of the fistula centers, and I was very pleased to see it was a fistula center in the northeast. I saw women who came from Lagos. I saw a woman who came from Niger. I saw a woman from Anambra. I saw a woman who came from Niger, and one from Borno, some who came from the northwest, who had all been repaired and without the cost to themselves. So this showed to me that this initiative is working. It's reaching the women, the vulnerable women who require the repairs of the obstetric fistula.
This program is aimed at supporting all women in Nigeria who are living with obstetric fistula, irrespective of the geopolitical zone where they are. So it's a three-step process, which is essentially one, identify and resolve whatever morbidity, which is a fistula in this case, that the woman presents with. And this is because, first, let's address the problem. And secondly, let's make sure that they are now enrolled in insurance after that. And then thirdly, let's make sure that we follow them up subsequently so that we ensure that they continue to access healthcare services.
Professor Ali Pate there and Dr. Kelechi Ohiri, who was appointed Director General and CEO of the National Health Insurance Authority by President Bola Tinubu in October 2023. 9 months ago, we had a robust conversation, and tonight he's here to give us an update on how well and how far he's leading the NHIA in areas of health enrollment, affordability, and accessibility. Dr. Ohiri joins me from Abuja studio. Good evening to you, Doctor. Thank you so much for coming on Politics Tonight.
Good evening, and thank you very much for having me. It's a pleasure to be here again.
Right, welcome to the program. The last time we had a conversation was March 2024, and I remember we talked about where the NHIA was before your appointment and your vision for the authority. The crux of our conversation was about accelerating the implementation of the NHIA Act and to improve health insurance coverage in Nigeria. From March, when we had our last conversation, and now, what has changed?
Thank you very much. And indeed, you do recognize that when we started from a baseline where we had a system where enrollment had stagnated for many years, and many reasons are responsible for that. We also had a system that was catering mostly to those in the formal sector and those who were in the organized private sector, and there was a need for the poor and vulnerable to be carried along. And we also saw a situation where, as the Minister of Health had outlined, there was a need to crash and address maternal mortality in Nigeria. And that's, with many other factors, represented the starting point. Now, over time, over the year, we have engaged multiple stakeholders, and this we're drawing from the vision set by Mr. President, who has made universal healthcare coverage a priority of his administration. And this has resulted in the health sector renewal investment initiative that is led by the coordinating minister, Professor Muhammad Ali Pate. And part of that involves improving access to all Nigerians. NHIA's role in that is to ensure that there is financial access to that. And I'll just give you a few results that we've had in a year, and then we can go into more detail. When we started, the number of Nigerians enrolled in any form of health insurance was about 16.7 million people. We had a target that was set that number needed to increase by 20% by 2027 when we look at the trajectory the country was progressing at. I think we're proud to announce that as of December, we had 19.4 million people, an 18% increase in that number, so just 2% shy of the 2027 target. And when we reconcile additional data coming in, it's very likely that we have already met the 2027 target and we will surpass it. But we also know that we're starting from a low base, so we're not going to relent, we're not going to be complacent.
All right.
It's important that Nigerians have more financial protection from catastrophic costs of healthcare, which is the primary reason why the NHIA is there, and therefore reduce health poverty across the country. The second thing we spoke about was the... Sorry, go ahead, please.
It's an established fact that universal health coverage means that people have access to the health services they need when and where they need them without financial hardship. As a country in the late expanding stage of population growth, with a population of over 200 million people with a high dependency ratio, the majority of Nigerians, particularly the unemployed, who are estimated to account for about 33% of the population, and the self-employed, who accounts for 81.37% of the total employed, have not been adequately covered by the scheme, with a coverage of just 3.4% recorded among artisans. For the purpose of clarity, where are we in terms of coverage? And in the year 2024, what numbers were recorded?
In the year 2024, an additional 2.7 million Nigerians were added. Okay. And this spans across the country, and this was a collective effort for everyone. And as you rightly mentioned, for a long time, health insurance in Nigeria was largely voluntary. It was largely focused on certain sectors, the formal sector and the private sector. With the enactment of the NHIA Act, it's made it mandatory. But then it takes more than just establishing a mandate to make people have health insurance. Awareness has to increase, and that means we need to let people know more about what they can do, that insurance is a better mechanism for accessing care and for financial protection than paying out of pocket. And so that awareness is something that we've started communicating, working with many stakeholders to ensure that health poverty is reduced. And by health poverty, what we mean is that right now, you pay out of pocket. And that means if there's nothing in your pocket, there's no health care to pay for. But even more ominous is the fact that even those who can pay something, if you're hit with a major catastrophic illness, it can plunge you back into poverty because you might have to sell what you have to afford that care. And to enlighten more Nigerians that it's really important to embrace health insurance as a means of not just having better health care, but also protecting yourself financially from the impact of healthcare spending. And I think that awareness has also helped, in addition to what we must do to continue to enforce the mandate of the law that it should be compulsory and everybody should try to have health insurance. So that was one of the things that we did.
All right,
it's also important to mention the role that other stakeholders have played. Just a second. Because I think these figures do not represent only what NHI has accomplished. Granted, NHI has played a leadership role, but we must give credit to the fact that we have engaged and had states, the state health insurance schemes. When we started, there were still some states that didn't have schemes. But in 2024, all states in Nigeria, all 36 of them, plus the FCT, have signed into law the state health insurance schemes that provide health insurance for the citizens of their respective states. And this has gone a long way as well to ensure that we've covered people, especially those who are poor and vulnerable. And that has also added to the numbers that we've seen. So it's been quite a collaborative effort,
I see.
Including the private sector as well. Yes.
But 2.7 million enrollments in 2024, and you also said all 36 states and the FCT now have schemes. How did you achieve that figure? And I'm asking because, last month I had a conversation with the Minister of Health, Professor Alipati. It was impressive to hear him say more Nigerians were insured by NHIA in 2024 than any other year in its history, with 2.4 million enrolled. And it was important to also confirm that number with you. But what kind of improvement in numbers should we expect in 2025?
In 2025, we're aiming to continue the upward trajectory, and we expect that we'll have a 20% increase in the numbers at least. And The truth is, we have a long way to go, and we at the NHIA will not be limited by targets. But we have set a target of another 20% increase in the numbers that we have as at December 2024. And we aim to achieve this in 3 ways. First, we must enforce the mandate so that employers ensure that their employees are covered. And this requires a whole of government approach. So advocacy with other arms of government, other NDAs, the legislators who have been extremely supportive will ensure that this compliance helps us, drive growth. The second thing is awareness, and as I mentioned earlier on, people need to understand, first of all, what is insurance? What is the benefit in it for me? How can it help me? And making sure that it's not just in the city centers, but also in the rural areas. Now that we have what I'll call an army with its health insurance schemes, the private sector, we need to ensure that this message reaches all Nigerians so that they can avail themselves of this. And then the third thing is really that of trust. Health insurance has to mean something to you, and NHIA has begun to ramp up its enforcement and complaints management system so that even when you're insured and you go to the facility, if there is an issue, if care is denied, complain to the NHIA, complain to either any of our state offices, and we will make sure that we enforce that. So that trust that when you have insurance and you show up at the facility, it means something, is going to be a critical part of our strategy in 2025 to make sure that enforcement starts. And we've already started putting in place the building blocks for that. And so with those 3 things, we are very hopeful that we will definitely increase numbers and continue the upward trajectory in the number of Nigerians that are covered by health insurance.
All right, thanks for going there, because I was going to ask you how you intend to surpass the 2024 enrollment rate and the strategies and modalities in place to achieve your targets, especially because of how Nigerians perceive or accept, anything that makes them pay more to government. We'll come back to this conversation in a minute, but we'll still talk about how the satisfaction with services rendered to beneficiaries and the problems with the remuneration of healthcare providers in the scheme. Let's talk about some healthcare initiatives by government which have been questioned. I've noticed an intentional effort to focus on vulnerable groups during the Tinubu presidency, but there was a report suggesting that the free C-section program is not being implemented. The report says C-sections are not being paid for. Data of potential beneficiaries, pregnant women, care workers are also unaware of modalities. Has the federal government been deceiving Nigerians?
Thank you very much for that question, and that is not true, and that is not correct. And the CMONC program, which is Financing Access for Comprehensive Emergency Care, is a program that has started. Right now, at least 899 women across the facilities that have started have had their treatments paid for. About 2,000 women received treatments, and then they were screened to see those who could afford and those who could not afford. That requires both doctors, nurses, and social workers who work with these indigent populations to determine those who require care. And then the claims are sent to NHIA, and then we pay. And we also have independent verifiers from the private sector who also verify these claims. The process is such. We believe very much that one of the ways to reduce maternal mortality is to make sure that when a woman shows up with an emergency in a hospital, that is not the time when she's bleeding or when she's having elevated blood pressure to start asking her, go here, pay, don't come here, go there, pay. Those delays in accessing care at that point can be fatal. And what we're trying to do is reduce that delay, called the third delay, by ensuring that ability to pay is not the reason why care is delayed or denied and that woman dies. And that has been the thrust. And we have done a lot since this program started. First, we have consulted broadly with the Society for Obstetricians and Gynecologists, who are those who are going to lead the clinical care for them. And I personally went to the annual meeting in Uyo, and we had a very productive engagement with them. We also engaged with the Committee of Medical Directors of Teaching Hospitals in Nigeria, where we again had a presentation that I led, and that we had questions, and some people signed up immediately. Right now, we have 42 teaching hospitals that have signed up to the program with clear MOUs signed with the NHIA. We've also written to all the states in the country, and we've been getting an outpouring of expressions of interest and facilities being identified. And of course, when you want to roll out a big program like this, you first start. Where are the women going? Where are they dying? And so we had all the data that we got from facilities, and we can prioritize. We started the program in Kano, in 3 of the tertiary hospitals that received most of the women in terms of volume and in terms of mortality. And we've been implementing there, and we've been paying for women who have complications there. We've also piloted University of Uyo Teaching Hospital in Akwa Ibom State, and that has been good. And other places, Abakatuma Balewa University Teaching Hospital, Bauchi, etc. And so when we started, we followed a data-driven approach to see where women go to. And we started engaging the states directly. And so it is absolutely false that the program has not started or that the program has stalled. Actually, the program is ramping up very rapidly. We are seeing many cases, and we are responding to them. So that is the real situation of things. And as at end of December, when we presented the last data, about 899 women who have had treatments, claims sent, validated, care paid for have been done. And we expect those numbers to continue to increase exponentially, to be honest, this year as the program goes on.
All right, Dr. Ohiri, let's stay on this for obvious reasons. I'm a woman first, and this has raised a lot of controversies. Now, you say, for the purpose of clarity, you say, because this program was announced in November, and that's about 2 to 3 months after, you have said tonight that 899 women have benefited from this scheme. Is that correct?
Correct.
All right. So what you're also telling Nigerians tonight is that NHIA is now spearheading a national free C-section program under your watch, paid for by the federal government. So a pregnant woman is watching us tonight and wants to benefit from this program. How does she go about it?
Thank you. And I think what is important, again, and I think this is one of the things where it's really important that we communicate appropriately. This program was announced in November. The work had started even before then. And the entirety of what the minister has said is exactly what I've told you. We know the leading causes of mortality in Nigeria. We have interventions at the primary care level, because at the end of the day, you want a pregnancy and childbirth to be a thing of joy, to be uneventful. So you want that when a woman has good quality primary care, good antenatal care, skilled birth attendants, that the pregnancy comes out normal, she has a regular delivery. And a lot of interventions are going on with our sister agency, the National Primary Healthcare Development Agency, to do that. But we also recognize that despite best efforts, there are women who will develop a complication. And we know what those causes are. It's eclampsia, which is elevated blood pressure in pregnancy. It's hemorrhage. It's infections. It's when labor is prolonged and obstructed. So these are some of the causes of why women die. And so what we did was, first we looked at it, and we had the advice and the counsel of experts in the field in developing this, in costing this, and in designing the pathway for this. So this preceded the announcement in November. What the minister has been communicating since is exactly that. Now, what does this mean for a woman? Now, for us to guarantee that the place where you go to also has the right human resources and you're going to get good quality care, NHIA has to accredit the hospital. And that's the process we're undergoing, which is when we get the data from where we start with where women go the most, then we accredit the hospital. Do they have the right health workers? Do they have obstetricians? Do they have a functioning theater? Do they have enough capacity to handle patients? And this is a process NHI has always been doing for other conditions.
Dr. Ohiri, don't you think all of this should have been in place? Don't you think all of this should have been in place before the implementation of this scheme?
Oh, a lot of them have already started. But you know one thing, and there are women all over the country that go to other places. But when you're talking about judicious use of government's finances, I want to make sure that they are appropriately targeted to those that need it. It's important, out of an abundance of caution, to make sure that the money is judiciously used. And we are ramping up very fast. So which means that between then and now, 42 facilities have already signed up. And those numbers are increasing by the day. And we anticipate that once the right foundations are put in place in these facilities, that we are on an accelerated trajectory to make this happen.
All right,
and so this is why we are doing this.
Right, we need to take a break, and when we come back, we will continue this conversation. Please. Welcome back to Politics Tonight, everyone. Thank you very much for staying with us on the program. Dr. Kelechi Ohiri, Director General and CEO of the National Health Insurance Authority, is my guest tonight. Tonight, we're looking at the activities of the NHIA, especially the record-breaking health enrollment, but most importantly, affordability and accessibility matters for healthcare. Thank you so much for staying with us on the program, Dr. Ohiri.
Thank you.
Right. So let's be clear once again. A pregnant woman already registered with, for instance, Bagada General Hospital, Luth here in Lagos, UCH in Ibadan, Nnamdi Azikiwe Teaching Hospital in Inewi, or let's say, for instance, Murtala General Hospital in Kano. Public hospitals in general, who needs to undergo a cesarean section, will not pay for it from our own pockets. That's correct. And you're also saying this initiative has kicked off. Because of the kind of conversations we've had in the last 9 months, you've said this initiative is aimed at reducing the high maternal mortality in the country. And from our conversation, only women in public hospitals registered under the National Health Insurance Scheme are eligible. So a pregnant woman who is not registered with any public hospital, but now sees that there is an opportunity for her, can she also benefit from this program?
First of all, thank you for the question and for making it very practical. If a woman is already under the NHIA's insurance program, this is already covered. So it's part of the benefits of insurance. This intervention was because of the recognition that there are, exactly like what you mentioned, there are lots of women that are not covered by health insurance. That's why there is a two-pronged approach to this program. First, treat the woman, make sure she's alive, and you treat the condition. Then you insure her using funds from the Vulnerable Group Fund and the Basic Healthcare Provision Fund to make sure that she is insured. So it's particularly targeted at people who do not have any form of insurance and who show up at those facilities vulnerable, cannot pay, and who otherwise would have been sent away. In Murtala, which was one of the first hospitals that we started, absolutely, that has kicked off. And it's not just going to be obtainable in public hospitals. We intend to cover a lot of the public tertiary hospitals where a lot of these surgical cases happen and these interventions happen, but also high volume private sector hospitals will be included eventually. And as you must admit, I mean, you asked a question as to why not wait until we have everything in place before we start. It's an emergency that we have, a maternal mortality emergency. And we have to start acting immediately. And that's why we have started immediately. And that's why we're seeing the numbers and we're seeing the progress and we're unrelenting in continuing to ramp up what we're doing. But that does not mean we will not do our due diligence to ensure that the government's money is used judiciously.
All right, yes. Dr. Ohiri, I wonder how you intend to cater to women in the informal sector. Because at the moment, Nigeria currently has the 4th highest maternal mortality rate globally, with a staggering 1,047 maternal deaths per 100,000 live births. I know that in a private hospital, the cost of this same procedure can range from 1 million to 3 million naira, depending on the complexity and additional postnatal requirements. So how much does this cost the federal government per delivery? And what data is the federal government working with?
So the good thing is that the NHIA has costed a lot of these services, and we pay fee for service where claims are sent to the NHIA, and then we review the claims the same way we would do so for any condition, and then we will reimburse the facility for the care provided to the woman. And it depends on the particular condition the woman has. In some cases, it will not require a cesarean section. In some cases, it might require blood transfusion. In some cases, it's just antibiotics because it's an infection. And in some cases, it might require drugs to bring down elevated blood pressure. So on a case-by-case basis, when the woman presents and is provided that care, the total cost of treatment is presented as a claim and it is reimbursed. And this is the mechanism that the NHI has used for many conditions, as well as for handling maternal emergencies for those who are covered. What we're doing now is increasing eligibility for those who don't have health insurance, well, because we have identified this as a vulnerability and classifying women at risk of dying as a vulnerable group in Nigeria that we should intervene and do something about. And that's why we have done it. So it's not a program for just for those who are covered. It's actually targeted at those who are not already covered. And that's why as soon as they are treated, then we enroll them in health insurance. Okay. So that after discharge, upon discharge, whatever ails them, be it obstetric related or other things, are covered. Because we believe very much that you should be covered for all the ailments that are in the benefit package that is being offered. All right. Even beyond, the obstetric emergency that we are treating.
All right then. So talking about private hospitals, are there plans to bring them on board?
Yes, there are plans to bring them on board. And if you take an example for what we've done with the fistula-free program, there are public hospitals. There are also private hospitals that are involved in that, who have been handling cases like that. Some faith-based hospitals receive a lot of patients, particularly the indigent and the poor. So yes, there is a plan to onboard the private providers, because in Nigeria we have a mixed health system, and so this is not something that will be limited to public sector. We are starting with the public sector because a lot of referrals go to the public sector, and we've also gotten a lot of data from the public sector, and we're starting our rollout from there. But yes, the intention is to get to the private sector.
All right, Dr. Ohiri. Now, to avoid running into stormy waters, I want us to talk about long-term sustainability, which, you would agree with me, requires a comprehensive approach that addresses the root causes of maternal mortality. Absolutely. How well is the federal government prioritizing investments in maternal health care education?
The government is prioritizing substantially, and if my colleague from the National Primary Healthcare Development Agency was here, he will tell you a lot about what the federal government is doing. First, they have launched a program called MAMI that has looked at the 172 local governments with the highest maternal mortality in the country. They are ramping up and revitalizing primary healthcare centers per ward. The government has committed through the Basic Healthcare Provision Fund 1% of consolidated revenue to primary health care. About 45% of that goes through the primary healthcare gateway to ensure that our primary healthcare centers are fit for purpose and can handle ANC, including maternal education, as well as some of the basic things, including safe, normal deliveries. The government is also investing in increasing the health workforce in spite of the JAPA syndrome that we have, to make sure that they are upskilled, they are trained, and they are deployed. And a very extensive program that the Coordinating Minister of Health and Social Welfare has launched in that regard. We complement this by ensuring that the financial access remains, and we also are part of the Basic Healthcare Provision Fund that addresses not just the supply of services, but the demand for services. And that's why under the NHIA Gateway, we work with the state health insurance schemes to ensure that the poor and vulnerable, once they are enrolled, we identify the primary healthcare centers that they can go to for care. And this is predominantly targeted at women and children under 5, but also includes other vulnerable populations per the Act. And so this facility is given a capitation fee, which is a fixed amount to cover that person's care for the year. That complements what the government is also doing by ensuring that you have the health workers and the primary health care center there. So that's to make sure that for basic care, that is covered. And primary health care is the foundation of any health system. And so that's been done. Now, where there are referrals for secondary care, and that is one of the new things that we are being intentional about under this government, which is recognize that when a woman is referred to a secondary hospital or she shows up, it's that care that we are trying to cover and the financial implications of that care that we are, because we know that despite best efforts, there will be those that will develop complications. And within that 24 to 48 hour period, you have to act. And that's what we're trying to make sure that we don't lose them because of any delay at that particular
I see the government is also
in summary, it's a whole sector-wide approach. And that's why the minister calls it a sector-wide approach, where we all play different roles in doing this. And what we're discussing is NHIS contribution. There are other MDAs and agencies that are also doing their parts to make sure that this is robust, comprehensive, and has the desired impact.
All right. So talking about efforts at providing free and effective treatments to women suffering from obstetric fistula, we know that in the grassroots of the country, people want to feel the improvement in their lives. Repairs for girls affected by VVF, are these transparent and accessible to those who truly need them?
Absolutely. And yesterday we had a steering committee meeting chaired by the Honorable Coordinating Minister for Health and Social Welfare, and had in attendance representatives of the hospitals that treat fistula, representatives of the Society for Obstetric and Gynecology, civil society, as well as third-party administrators, lots of people in a steering committee, and we presented the data. This program was launched about 6 months ago, and as of now, almost 1,700 women have actually had fistula repair, treatment, and surgery paid for through the NHIA to do that. And lots of these women come from areas where, they are rural. These women tend to be poor, and they tend to be people that are socially excluded as a result of the stigmatization of these women for something that can be repaired. So again, the commitment of the government to addressing what the minister calls physical and financial pain is part of this. So we work with the community-based organizations. We work with the hospitals who see some of these women who come in and cannot afford to pay for their surgeries. And then we cost it, and then we make sure the same principle applies. When any woman in Nigeria, and I said in the clip, you said, who has obstetric fistula, can go to any of these accredited centers. These are centers that normally provide these fistula repair surgeries. And you will get it treated. You will not pay out of pocket. And NHI will reimburse the facility for the treatment, and then we will enroll you in insurance. And for this particular group of women, because of their socioeconomic situation, even feeding when they are on admission and receiving treatment is paid for. And now the minister has directed that we start working with other sectors like the Ministry of Women's Affairs, including the NDE, so that when they are discharged, they are adequately and properly rehabilitated in the communities where they go. Because you're not just saving lives, you also want to restore livelihoods for people who had been ostracized by society. And that's why we are seeing an exponential growth. When we started the program in July, you had women coming in trickles. But as soon as word went out, people knew somebody in their village that had the condition. We started seeing a lot more referrals. And that's why we have over about 1,700 cases paid for, about 1,800 claims have been submitted. But remember I said, when the claims come, we make sure it is vetted by the NHIA, and we also have independent verifiers that vet the claims to make sure they are credible and that they adhere to the right treatment guidelines. And then we pay, and this is reviewed weekly that this is done. And hence, that's why we're seeing a large uptick in the numbers.
Quite impressive, because I wanted to ask if government also covers associated costs like feeding, transportation, and post-care follow-ups. But how many steps are the treatment process?
Yes, it does. Sorry, say that again, please.
How many steps are the treatment process?
So when a woman comes in, right, so depending on the severity, in some cases they are managed conservatively, in some cases they require one surgery, in some cases that are really bad, they require multiple surgeries. All of them are paid for. So the process is when they show up, treat them, sort out the condition. While they're on admission, feeding is taken care of, transportation is reimbursed. And then when they are there, we also have things like making sure that they get NIN numbers, so some form of identity inclusion for them. And then when they're done, we discharge them. But before we discharge them, we work with our state health insurance agencies under the Vulnerable Group Fund to come in and enroll them in insurance. And then they are followed up afterwards because they have to have follow-up checks after the fistula repair.
All right, Dr.
So that even subsequent pregnancies and deliveries will be
because of time,
done.
How many accredited facilities do we have handling this treatment across the country?
We are currently working with 18 of them across the country in each geopolitical zone. We're about to add 2 more teaching hospitals that can do this.
All right.
So that will be about 20 in total.
Well, you understand that that's quite low, right?
It is not an easy surgery. And as we even, learned more yesterday, it requires really specialized, skill sets. And it requires gynecologists who have been trained in how to perform these surgeries. And depending on the complication, in some cases, you actually need, people who have had almost like an additional specialization in this. So it's not something any obstetrician can do. So it's a different level of complexity compared to, say, doing a cesarean section. That's why it's not all hospitals that offer this. But any hospital that offers this, we will accredit and engage. So the limitation has not been because we do not want to work with other hospitals. It's those that we go and accredit and make sure that they have what it takes to provide good quality care to these women.
All right, Dr. Ohiri, let's move on to other matters. Let's talk about primary health care. I know you're a medical doctor and you've worked as a primary care physician in various healthcare settings. Your extensive experience in the healthcare sector spans clinical medicine, consultancy, and advisory roles in both the public and private sectors. Let me take you up on primary health care, which is an area that Nigerians have long complained about. The Ministry of Health has set the ambitious target of doubling primary health facilities in Nigeria from the present 8,800 facilities to over 17,000 within the next 4 years. Are we actually on course to achieve this?
So thank you very much for that question. I wish my colleague from the National Primary Healthcare Agency was here to speak to that. But just to respond to you, when you look at the policy, which was initially have one primary healthcare, functional primary healthcare per ward, the numbers come to about 8,000. And if you have 2 per ward, which evidence shows that that is what is needed to meet the access requirements in terms of geographic access, hence this. These primary healthcare centers exist. What the government is doing is trying to make them fit for purpose by assessing, okay, do you have the full complement of primary healthcare workers to provide care 24/7? Say the woman in question shows up at 2 a.m. That means you have to have a full complement of skilled health workers, nurses, midwives, etc. And now the Primary Healthcare Development Agency has started first by identifying again, prioritizing where are most of the women going and where are they dying. And they are scaling that up. And I believe that they are on track and they will get there. And the Primary Healthcare Agency even has a website. I don't have the number, but I'm sure it can be pulled off their website, where you can go and see illustrated everywhere on the map of Nigeria where these centers are. And if you click on any of them, you will see exactly what they offer. Number of health workers, services that you can actually avail yourself of when you're there. So anyone can go and check it and see it. So yes, and they are doing that. Now, Nigeria has made a decision. And that decision is that we will build our health system on the foundation of primary care. We will expand access, but we don't want a trickle-down situation where first the rich and the wealthy get care and then the poor catch up later. That's why this administration has focused a lot on the poor and the vulnerable so that no one is left behind and we go together and we realize universality together. And that's why a lot of focus on primary care. The last point on that is how, as our health system evolves, we do not want everybody to fall sick. And that's when you show up with the health system. We want to emphasize prevention and primary care so that it should not be the first time you're realizing you have hypertension is when you have a stroke. It should not be that the first time you see a doctor is when you're having a bleeding or hemorrhage in labor.
All right.
No, we want to make sure that the care is there in the communities.
All right, Dr.
People have the right
sadly we're
primary
out of
care
time.
and prevention intervention so that they are healthier.
All right.
It is a
Sadly,
better
we're out
outcome
of
for the
time,
country.
Dr. Ohiri, but I'm sure we'll
also
continue.
more cost effective.
Right. I'm sure we'll continue this conversation some other time. Thank you so much for joining us tonight. Dr. Kelechi Ohiri is the Director General and CEO of the National Health Insurance Authority. I must say well done, and I wish you all the best. Thank you so much for joining us on the program.
Thank you very much once again, and thank you for having me.
And thank you very much for watching, everyone. That marks the end of today's episode of Politics Tonight. But you can watch the repeat broadcast of this episode at midnight. Get in touch with us on our social media handles, Facebook, Instagram, and X at TVC News NG and at Olajumoke using the hashtag Politics Tonight. We're also on YouTube at youtube.com/TVC News Nigeria. I am Olajumoke Olatunji. Have a great weekend.